We are going to be having a conversation focused around our care partners today. This is actually a three-part series. This is the first part in our three-part series that we're doing in collaboration with Gil Kieran. Some of you may have participated in a survey that we sent out, and this program and the next two following it are going to be kind of discussing some of the data points that we found from your completion of the survey. So I'm very excited about this conversation just because I feel like it's a very important one. So before we get started, my name is Anissa Mitchell with PMD Alliance. I want to invite you to open up your chat box. We're going to be asking you to ask questions throughout this program today, comments, whatever. We're going to have a conversational style program today. There's not any PowerPoint slides, so there's none to make available to you. It is being recorded, so you can go back and watch it later. But this is a conversation. And so we're going to be talking about some specific things, but we want to include you into that conversation. I want to frame this a little bit first before I get started around some of these survey results that we're going to be discussing today. And from that, we did create some toolkits. So if you pre-registered in advance before today, you probably received in your email a download of some of the toolkit items that we're going to be talking about today or referencing. If you just registered and popped on, we will be sending these to you in follow-up and email. And I think Alyssa might be able to drop those in the chat. So the first one is called Roadmap to Care, and it looks like this. It looks like a little road. We're not going to actually be going through it today, but we will be referencing it. And it is actually meant for you to use ongoing. So this is just sort of a resource for you. And then we did a series with Kieran last year, and we did a program called Asking for Help and Planning for the Future. And so some of those documents have been sent to you again this year. So we just invite you to utilize these, however it will support you. So when we did the survey with Kieran, we surveyed 752 care partners. Many of you, I hope, were a part of that survey. And that data indicated that 38% of you are challenged by understanding information about the progression of the disease. 31% indicated they lacked a structure on how to be the most effective care partner, and 29% indicated a challenge in understanding all of the information about the disease. And I know from facilitating a lot of programs online, I get comments in the chat of, I just want to know how to plan for this disease, at each stage. Can someone tell me what to expect? And what should I be doing? So that is what we're wanting to address today. So with us, I'm very excited to invite into this conversation is Dr. Christina Vaughn. Dr. Vaughn is a movement disorder specialist. She is associate professor of neurology and medicine at the section of neuropalliative care at the University of Colorado Anschutz Medical Center. And after she had obtained her fellowship training in movement disorders and practiced for a while, she actually decided that she wanted to broaden her scope, and she went back for a fellowship in palliative medicine in California. So she brings her expertise as a movement disorder specialist as well as an expert in neuropalliative care. And we're going to be talking about what that actually means. But I want to just invite this conversation with Dr. Vaughn to first kind of talk to us a little bit about an interdisciplinary team approach. So it's important for us to understand what that means and how this can help someone at the time of diagnosis and throughout the entire journey. And it's really important to look at this from a long game perspective, but start having conversations early. So, Dr. Vaughn, I want to talk a little bit about what it means to be person-centered.
Sure. Can you hear me okay?
Mm-hmm.
Great. Well, thanks so much for having me. I'm really happy to be here with you all today. There are a lot of kind of buzz terms circulating around in the medical world, and person-centered is one of them. And I think it's not to be ignored. It's a pretty important concept. And person-centered, it sounds pretty obvious what it means, right? That the person or the patient, the person who's coming to see the medical provider, is at the center of the care. Okay, what does it really mean? Well, the WHO, the World Health Organization, came up with a definition which is about empowerment of the patient or of the person with the condition that we're talking about, in this case, Parkinson's. So the WHO says that person-centered care is empowering people to take charge of their own healthcare rather than being passive recipients of service. And I think to distill it down even more, it's the idea that interactions with your healthcare team or your medical provider aren't just transactional. It's not just like, here's my symptom, here's your drug, or here are my symptoms, here's your diagnosis. It's meant to be a lot more robust. And it's really intended for the physician or the care provider to try really hard to get to know the person in front of them and their family, whoever's important to them, to really try to understand their lived experience, in this case with Parkinson's, whether it's the care partner, another family member, or the person, of course, with the diagnosis, to really understand what that means and to really try to understand what the person's care preferences are, what their values are, what's most important to them. Because as clinicians, we can make all sorts of assumptions. We're good at making assumptions about what we think is most important. If somebody comes to us with a pretty significant tremor, we might assume that, oh, I'm sure they want their tremor to be the focus of our care today. I'm just going to focus on that, and if they don't ask, the provider's not really going to understand that. In fact, maybe it's the soft voice. And this was previously a very outspoken, energetic, social person who has hypophonia, or really soft voice from their Parkinson's. And that is the biggest issue that they're dealing with right now. But unless we ask, we're not going to know. And so really trying to keep the patient at the center, although it sounds obvious, sometimes it's not. And you find yourself in a situation where your medical care is based more on assumptions without the care team taking the time to really understand what's most important at that moment in time, knowing, of course, that that can change. And when you have Parkinson's or you're living with someone with PD, you're anticipating a road of years of living with this and trying to live as well as possible during that road. And along the road, having a care team that through multiple visits along the way has established a relationship with you and really seeks to understand and get it. No one's ever going to be quite in your shoes, and people are going to try to understand, but never quite be in your shoes, but still in trying, really try to understand the preferences and values of the patient and family and care partners around them. So that's one bit of person-centered care. I'll pause there.
Well, and I think a big part of this is that a lot of people kind of, when they first get diagnosed, they just want to live their life. And so, but a couple of things happen. Like for some, the world just, stopped and they got this significant diagnosis. And that's the experience maybe of the person that's actually diagnosed. And then the care partners have their own experience. And, a lot of times they don't talk about those values, like you were saying, like it's not the tremor I'm focused on, it's the voice that's changing, or the fact that my spouse keeps telling me to speak up and I'm talking loud, I don't understand, and it's causing friction between us. And so it is not just a simple symptom, it's actually relational, it's psychosocial. Can you talk about why it's so important to take a proactive approach to symptoms, whether it's a tremor or it's, more of the shuffling steps and, talking early and, addressing them early, whether that's medication or it's therapy or whatever that case is, that actually can help their disease, that it actually can help the journey and the trajectory of the disease.
Yeah, it's a tough balance when we're first meeting somebody who is newly diagnosed, or we're first making the diagnosis of Parkinson's disease. It's a balance between wanting to give someone all the information, or give a family all the information. Not that we could possibly ever do that in one visit, but also trying to leave space for the reaction, for the processing of wow, how did that land with you? Or how are you wrapping your head around this? And it's so different. I mean, one thing we know for sure about Parkinson's is how variable it is, right? You see someone with a tremor who's got PD, and someone without a tremor who also has PD, and they have the same diagnosis and maybe the same medication regimen, but they both have Parkinson's and they look quite different. Similarly, there's variability about good and bad days. There's all sorts of things that it's hard to generalize a lot in Parkinson's. And so if someone's met someone with Parkinson's prior to being diagnosed, or a family member has had it, it's easy to make, again, assumptions about what you expect is going to happen, because maybe you've seen it before. I mean, over 1 million people have Parkinson's in the US. We see it because there are various people now, and there have been for a long time, like Michael J. Fox and Linda Ronstadt. We could go on, right? There are people that we know of in the limelight sometimes who have PD, and we get these ideas of what it should look like or what it usually looks like, but it's so variable. So when we're early on in the condition, we really, as clinicians, need to explore what someone already knows or thinks they know about Parkinson's, what their prior experiences have been, and also ask them how much they want to know at this point in time. Rather than assuming and forcing all this information on someone, maybe it's best for that person or that family to do this in bite-sized, shorter visits over time, over a shorter period of time, if possible. Maybe it's better, and the person says, you know what, I want to read about it. Do you have some good resources for me? And then I'm going to come back and ask you questions. It really depends on how that person and family and care partner want to receive information, how much they want to receive, and also trying to strike a balance between providing information and being there for support and helping people wrap their head around what it means. And I think early on in the condition, all too often patients and families don't know what to ask. And I think particularly in neuropalliative care, which is the way I practice, one of the things we like to do is to suggest questions. Would it be helpful to talk about what the future looks like? Would it be helpful to talk about what the next year could look like? Would it be helpful to, suggesting questions that would be helpful, because it's hard because at the end of the day, you don't know what you don't know, right? I say that probably hourly in my own life. You just don't know what you don't know. And especially if you've not encountered Parkinson's close up, and even if you have, as I described, it can be so variable, it's hard to know. So I think it behooves providers to be ready to suggest topics and see if people want to talk about them. And it also is important for patients and families to be empowered and feel empowered to make sure that all your questions are going to be answered, and that you say, hey, I've got a bunch of questions. Can we go through this now? Or, how best for us to cover all this? I'll pause there. I think Anissa, your points or your questions, you had multiple questions and I want to tackle them all, but I also want to pause and see if you have some comments or if anyone else does.
Well, yeah, and I'm watching the chat for comments. I think this is a perfect segue into the next question. And I kind of want you to define, because the way you're approaching it is not the way that every practitioner approaches it, and kind of gauging each person's needs, responses. I think that's the way that you do it. So can you talk a little bit about what neuropalliative care is? Because I think a lot of people cringe at the word because they associate that with end of life care, hospice care. And I think what we're talking about is a much broader, much more proactive approach to care that includes, restorative, prehabilitative, whatever words you want to use to maintain quality of life, and treatments and all of that. And I think that would be helpful for people to understand, even if there's not a program, that there's still an approach that they can take to it. So I would love it if you could spend a few minutes just kind of demystifying that a little bit.
That's a good word. Yeah. And words matter. So yeah, it's good. It's a good time to define neuropalliative care. So basically, it's really two things. If we boil it down, palliative care and its application to neurologic disease. So neuropalliative care is an approach to care, and it's a medical specialty. So I'll start with the approach to care. And what the approach is certainly person-centered, focusing on trying to get to know the patient in front of you and understand who they are as a person before diving into the medical, and focusing not just on symptoms, but also coping and future planning. And really, this is best provided by a team, an interdisciplinary team, meaning a team of folks from different medical specialties, and not just medical, sometimes a social worker or a spiritual counselor like a chaplain, all working together on a team to try and bring their own skill sets to identify sources of challenge for patients and care partners and families living with a chronic condition. And so palliative care, in this case, neuropalliative care, is appropriate for anyone with a chronic, serious illness at any stage of their condition, even at the time of diagnosis. And so this team is setting out to, again, focus not just on symptoms, physical symptoms, but thinking about coping, support, and future planning. And I think oftentimes when someone is newly diagnosed with something like Parkinson's or atypical Parkinsonism, there's a lot of questions about what does the future look like, and what do I need to do now? What makes the most sense? And it can be rather overwhelming. And that's why I think the palliative care approach, or working with a palliative care team, can be so useful at the time of diagnosis and any time after that. Some people don't have access to a palliative care team or a neuropalliative care team, but I'll tell you, these are becoming a lot more common in the neurology world. If you've heard of palliative care before, perhaps you've heard of it in the context of oncology, cancer, or heart disease, liver failure, those kinds of things, not related to Parkinson's. And while palliative care was born out of other medical conditions, it is now becoming extremely popular in neurologic conditions, whether it's Parkinson's or any other neurodegenerative disease and some others. You can find out more if you want to by Googling the International Neuropalliative Care Society, which is the INPCS, which is newly formed and really gets into more detail about the application of palliative care to neurologic conditions. But I think there are many time points along the trajectory of Parkinson's where a palliative care team could be particularly helpful. For example, around the time of diagnosis, meeting with a palliative care team could be a time to really understand goals of care. What's most important now? Because early on in PD, what are we trying to do? We're trying to empower people to live as well as possible, and ideally to put the Parkinson's on the back burner, to not poo-poo it, certainly, but also to not have it be the be all and end all, the center of life, but to figure out, okay, I've got this condition, now what? How can we manage it aggressively and get everything, the medications in place and all of the other therapies and so forth, and get on with life. So palliative care could be helpful at that time in thinking about what's most important now. Having a visit where you're talking about who you are, what you're hoping for in the future, plans that you have, and then your medical team learns more about you and is able to help you moving forward, thinking about, okay, well, for this person, it's really important to continue working. How are we going to help them do that? Maybe we're going to be more aggressive with medication than we would be with someone else. Maybe we're going to focus on this kind of therapy and not another kind of therapy, if that's their goal. To take the time to understand somebody's goals and values is really at the heart of the palliative care approach, or what a palliative care team is doing. And so if you're a patient and a family early on in the course of Parkinson's disease and want to think more about this kind of approach, this is where you come to your physician or your care team and say, hey, I've heard about palliative care. I understand that it's really focused not just on symptoms, but coping and future planning. How can we incorporate some of that into our care together? And that can spark new conversations with your current provider if you don't have access to a palliative care team, if that's the sort of care you're wanting to incorporate. I'll pause there.
Yeah, we had a comment that a palliative care doctor told this care partner that his patients are all end stage and are not walking and eating. And is that
not true? I'm sorry that you were told that. And that is an old view that is completely inaccurate. And certainly I don't doubt that somebody said that to you, because there are some people that hold strong to that belief. Palliative care simply means, it comes from a word which means to cloak. And I love this word because it's like another layer of support. That's the essence of it. And unfortunately, people often associate it with hospice, and I would prefer so much to define it by what it is rather than what it isn't. And so what I've tried to do so far in this discussion is talk about the role for it and what it looks like, and that is another source of support. But I really want to be strong in saying that there's no palliative phase of Parkinson's, or frankly, any other condition. Any chronic condition can make use of palliative care as a team or as an approach to care. And I apologize that there are still folks out there spreading misinformation that it's reserved for end of life people that are at very end stages. And what that is hospice care. Mm-hmm. Hospice care is reserved for people that are at an end stage of their condition, who are expected to have a short lifespan of 6 months or less. That's totally different, not what we're talking about. I think there's some more questions coming through.
Yeah, and I know one of the main ones that people want to dive into is sort of each stage, like what are the tipping points? What are the things that people should be looking for, concerns? So maybe we can just start, like you've kind of addressed a little bit about the early stage, but is there something around this stage that are kind of like the key things that a care partner should be most concerned about?
An early stage?
Yes, we'll move early to make, because I'm thinking things like addressing mood issues and those kind of symptoms that might come up.
Sure. So first of all, the topic of staging is a really common one in Parkinson's. And I'll tell you that it makes sense that people want to know what stage they're at. Whereas again, in other conditions like cancer, we've got stage 4 metastatic cancer and other stages. And that means something about prognosis and potentially about the kind of treatment someone's going to get. In Parkinson's, we don't have an equivalent staging system. There's a staging system called the Hone and Yahr, Hone, H-O-E-H-N, and Yahr, Y-A-H-R. And that is not a helpful staging system. It's simply a snapshot of what a patient looks like on that day by the clinician, describing what their balance is like and what their symptoms are like and whether or not they're using an assistive device. So I just want you to know before we dive into stages that there is no good staging system as there are in other diseases, right? Knowing that you're a stage 2 Parkinson's isn't helpful about the future necessarily, because people can stay in a certain stage for a number of years. There's no hard, fast rules about how long you're in a certain stage. In fact, somebody who's a stage 3, which means that they have balance problems now, if they do aggressive physical therapy, sometimes people from a stage 3 can go back to a stage 2 for a period of time if their balance improves. So again, when it comes to staging, the best thing we can do, I think, is what the PMD has done in the toolkit, which is to highlight early, mid, and late stage. That's the best we can do, for better or for worse. So let's talk about early stage. I think some of the struggles that people have that kind of creep in, maybe not dramatically obvious right away, are things along the lines of mood disturbance, whether it's new anxiety, where somebody feels more anxious than they once did. Maybe they had a tendency towards anxiety, or maybe they didn't, but now they're just more anxious, the person with PD. Sometimes it looks like anticipatory anxiety, going to appointments, having deadlines. This becomes a bigger source of anxiety. Or starting tasks or completing tasks cause a lot more anxiety. Just getting started becomes this bigger hurdle than it used to be. Sometimes these kinds of symptoms just kind of creep in and are subtle, and maybe not even recognized as related to the Parkinson's disease. Because again, if it's creeping in slowly, it's sometimes harder to recognize. Another thing, which along the mood topic, which can be sometimes problematic in any stage, including early, is apathy, where people are perceived as having no motivation or less motivation, less get up and go. And part of that can be misinterpreted because facial expression is now diminished. People have less facial expression, and it's harder to read where they're at with interpreting things or how excited or interested they are in something. But other times it's strictly apathy, a less motivation to do things. And that can be a huge source of friction between people with PD and their loved ones, because the loved one's like, why are you still sitting on the couch? Or why are you not doing X, Y, and Z? And that person's like, I don't know. And could it be depression? Sure, but it doesn't have to be. Apathy can exist on its own, completely unrelated or not connected to depression. Someone can be perfectly okay and content and not depressed and still have apathy. So I think that's something too that's often not recognized, and that can be present early in Parkinson's and can be addressed. Sure, there's no medication for apathy, but there are techniques, and just acknowledging it and naming it is the first step, because then you know what you're working with. So I think focusing on some potential mood problems early in Parkinson's can be helpful, particularly for later on. If we get a good handle on it and fully try to understand what's going on, it can help in later stages. I think, always staying active and moving is really critical at any stage of Parkinson's. It's never too soon to start to have some sort of regular cardiovascular routine or stretching routine, or both. The mantra becomes use it or lose it, or move it or lose it, like right from the get-go. The only thing we have that potentially slows down the progression of Parkinson's is cardiovascular exercise. I wish that I could say that we've got X, Y, and Z supplements or X, Y, and Z medications. We don't yet have those things. We have exercise. So exercising in early and all stages to the extent possible is critical. I think as far as care partners go, it's a tough balance between encouraging your loved one and nagging them. And this becomes a tough topic too. How do you support and help and not create more resistance or friction? And that's a tricky thing. I think that's worth bringing to your care team too, to talk through. If you're finding that you're trying to make suggestions and your loved one with PD is not wanting to listen or having selective hearing, I mean, absolutely, your medical team or your care team should be able to help guide you through that, or arrange a family meeting. That's another tactic palliative care teams like to have, is to have a family meeting where the goal is to talk about, the dynamics, what's going on, why are you not following through on these things? Is it apathy? Is it actual hearing problems? Is it memory problems? What is it? Is it just you don't want to? The other thing that care partners can do early on in early stages is make sure that medical power of attorney or healthcare proxy is all in order, not just for your loved one with Parkinson's, but for you. It's an opportunity to think, oh, we haven't done this yet. Let's just do it. Let's name who we would want to be our voice if we couldn't speak for ourselves to make medical decisions, not financial, strictly medical. I think it's never too soon to have that documented for anyone at any stage of life or age. And this is another opportunity that we like to talk about in palliative care. Who's your person? Who are your people that you trust the most to make medical decisions? So doing that early on in Parkinson's is great to do, because now you've done it. And in the future, if it changes, you want someone else in that role, or change the order of who's in that role, you just do that later. We've already talked about it. Those are some of my thoughts on early stage. I think you're following.
Sorry, go ahead.
No, go ahead.
Well, I was just going to say, I think that knowing that a care partner's tasks and stress increases as the disease goes on and the needs become greater, anything they can do early to help them later, like getting the healthcare surrogate, the proxies done, that's just one less thing on your task list. And if a crisis occurs and you can't be available for your loved one, or they're alone and they need help and they don't know who to reach. It's important to have this information so you can be prepared in a crisis instead of trying to work in the midst of a crisis.
I agree. And that crisis word is important. I love to say to people, hey, let's acknowledge that we're not in a crisis. I really like to highlight that in visits and say, this is the time. We're not in a crisis. I'm not saying things are easy, but we're not in a crisis. I'm not saying we're ever going to get in a crisis, but what we want to do when we're not in a crisis is think through the what ifs. What if the care partner got really sick? Who's the backup, or what's the plan? What if stairs became just insurmountable at home, and we've lived in this multi-story home for however many years, a really long time? What if we just can't manage the stairs? Does it make sense to have the bedroom on the ground floor and live on the ground floor? Does it make sense to get a stair glide? Does it make sense to downsize? Does it make sense to go into another kind of living situation? These are the what if scenarios that, again, palliative care likes to bring up, but you can bring up with your medical team. I was thinking about the future and thinking about the fact that this is a progressive condition, and thankfully a slowly progressive condition, but it's never too early to think about the what ifs. What if this, what if that? And so in a non-crisis period is the best time to think about the what ifs.
We did have some questions because, apathy really is a huge stressor. If you mentioned techniques, can you mention a few of the techniques that they might be able to? Yeah.
It's tricky. I think the first thing we want to do is sort out, is this actually major depression or not? And that's hard too, but that often a medical professional should be able to do that by asking some questions and hearing about what's going on. Like, walk me through your day. I love to hear about someone's day. How does it start? What do you do during the day? Are you napping? Are you spending most of your time just sitting in a recliner? Are you spending your time doing this and that? Really trying to understand how someone's spending their time in general and how that compares to how things were a year ago, 2 years ago, something like this, to really see what the difference is. If this is previously a very introverted person that doesn't interact much, okay, it's good to know how this compares. So really trying to tease apart depression and apathy. Depression can be treated, even though Parkinson's can't be cured yet. Sometimes depression can be, or at least well managed to the point of being a thing of the past. Depression, actually, there are many strategies to treat depression. So really trying to identify if there is treatable major depression here and dealing with that. If that's been ruled out and we're really clear that what we're dealing with is apathy, is really talking through that with the person living with PD and their loved one and saying, okay, apathy is defined as this. Let's think about times in your day when you think apathy could be playing a role. Like, remember how you wanted to do X, Y, and Z, or your goals are to go on this trip or to plan this thing. And why isn't that happening? Well, I just don't get around to it. How can we strategize together to come up with ways for you to have bite-sized goals in making progress on some of these things you want to accomplish, and really trying to give people tools? It's easier said than done. I know, but sometimes using your medical team to be accountable. Just yesterday, I saw a patient with pretty advanced Parkinson's and some degree of dementia, and he and his wife are trying a trial period of living at home, previously having lived in a facility. And we're meeting every 2 months-ish in the hopes that some progress has been made in getting more help at home and having a safer environment so that they feel accountable to me, in this case, and my team, to make progress and not just be stuck in sort of a period of apathy. So really relying on your care team for accountability, trying to see if there's a pattern in the day with the apathy. Sometimes the apathy is influenced by off periods. When somebody is more mid-stage or late-stage Parkinson's, there can be major off periods where the medication's not working. During those off periods, somebody can feel really lousy. They can feel depressed. They can have apathy. They can have fatigue, less motivation. All of that stuff can be really linked to an off period. So trying to see if there's any pattern in this apathy, things we could tinker with or influence with respect to timing of medication is another way. But really making sure that the family is on board with understanding and recognizing what's apathy, so that there can be less potential friction and frustration about why it's happening, and really understanding that apathy is a symptom. That doesn't give everyone a free pass, right? I'm not doing anything, But really trying to educate yourselves and having conversation with your medical team, your neurology team about whether this is apathy or depression. And if it is apathy, trying to come up with some strategies together and some accountability and seeing if there's any pattern during a day with respect to on and offs. Those are some starter ideas.
Fantastic. And I think this is a perfect segue of going into some of the topics around the mid stage, like some of the challenges care partners might face, things that they should be looking at. You already talked a little bit about off. Maybe we can dive into what that might look like and why it's important for care partners to be familiar with it and to be able to help make sure that the physician's aware of it so that it can be addressed.
Yeah, I think over time as PD progresses, the non-motor symptoms become more prominent. By non-motor symptoms, I mean often the invisible symptoms that someone on the street wouldn't notice, right? Certainly you can notice a tremor or walking problem or slowness. You can't really notice apathy. You can't really notice a sleep disorder or anxiety, depression. There's a whole host, fatigue, right? There's a whole host of non-motor symptoms that aren't so obvious to the outsider that become much more prominent and problematic in mid to later stages of Parkinson's. So for care partners to familiarize themselves with the whole host of potential non-motor symptoms, I think is important. It's a tough thing here because when you have a hammer, everything's a nail, right? So it's easy for someone like me to blame all sorts of symptoms on Parkinson's. We don't want to get carried away on the other hand, right? We don't want to miss something else that's going on. For example, pain, that's a non-motor symptom that can be part of Parkinson's disease, is often overlooked. We don't want to get hung up saying, oh, this pain is Parkinson's related and overlook a workup that could be looking at spine imaging and other things. On the other hand, we don't want to ignore the fact that pain can be part of Parkinson's. So really familiarizing yourselves with what the possible symptoms are, particularly non-motor symptoms, I think can be useful so that when you go and see your medical team, you think, okay, I really want to highlight to you X, Y, and Z that I'm seeing. I'm not sure if this is Parkinson's related or not. And then the clinician is going to probe further and say, well, ask some clarifying questions and help you try to determine if that is PD related and what to do about it, if it's bothersome. So I think familiarizing with non-motor symptoms is really important at mid-stage. I think overall, just symptoms, even the obvious ones are more severe, right? Balance becomes more problematic and people are relying more on assistive devices. I think, I have a problem with canes because canes get underfoot and sometimes trip people up and force people to be asymmetric. Parkinson's is already an asymmetric disease, right? It starts most on one side, spreads to the other side, but remains most prominent usually on one side and is always more affected. There's a more affected side. And so the more things you can do to try and establish symmetry, the better. So walkers, are more symmetric. You have to hold it with both hands. Swimming is an activity that really forces people to try and be symmetric because if you pull too hard in one direction, you're going to turn. So using a cane, it's not my favorite thing. Sometimes it's better than nothing. I do like walking poles here in Colorado. It feels like lots of people use those with or without Parkinson's because it's Colorado. But using assistive devices becomes more common once in the mid stage of Parkinson's. And that's a tough conversation too. I mean, that's a big adjustment for people to have, lived their whole life potentially without having to think twice about walking in balance and now suddenly having to be more cautious, which might prevent them from going out as much. And then they become more isolated. So we really try to have early conversations about balance, getting out, trying to avoid isolation, and thinking about how to normalize some of these fall problems, potential fall problems, and having a safe space, making sure that your house is set up in a way that's most conducive for safety. And sometimes it's hard to know. Again, you don't know what you don't know. An occupational therapy consult Could be a home safety assessment where an occupational therapist comes to the home one time and gives suggestions about things like grab bar placement or getting rid of loose rugs or creating more space and avoiding tight spaces if possible. You know, all sorts of suggestions that perhaps you haven't thought of because you've lived in that space for so long, maybe. So thinking about safety and balance is also an important new feature as somebody enters the mid stage of Parkinson's. I'll pause there.
Well, and falls are such a huge concern for people. And, you know, once you have a fall and you end up in the hospital, that's a whole nother challenge. Absolutely. Hospitalizations and not often being able to directly come back home, but, you know, the whole challenge of getting meds on time and, you know, them understanding the disease and people needing to get rehab. And so if we can avoid that, getting therapy regularly, having somebody evaluate the home for safety concerns. And again, talking about this early so you can plan, so you're not having to make challenge or these kind of challenging decisions, you know, forced on you, but you've thought them through, you've been planful and mindful about it, because that does add to the stress on everyone, but especially the care partner. Another thing, you know, aside from falls and dealing with apathy and all of that, is dealing with maybe some cognitive and behavioral changes that might surface at this stage. Can we spend a few minutes on that?
Sure. I just want to make one point that relates to all of this, and that is that I saw someone's comment about their movement disorder specialist being a compassionate member of their team, and I'm so glad. And I just attended the Movement Disorder Society meeting a couple weeks ago, and I love my colleagues in movement, and I think that people who are drawn to this field tend to be really compassionate and wanting so much to help. I think, unfortunately, the time constraints imposed by medical systems and all of the restrictions on the amount of time people can spend really get in the way of medical providers being able to ask all of the questions that they want to ask, because there are so many things to talk about, like we're dealing with now. So the more that you and your family can be aware by trying to educate yourselves and looking at roadmaps like this as a starting point, I think the better, because then you can really come in with an agenda as much as possible to say, here's what's most important, or here's what's most bothersome, and try to partner with your team, your movement specialist, to focus on what's most important, because time is so short in these visits. It's pretty awful, which is another reason why sometimes the neuropalliative care team can come alongside and have staggered visits to allow for some of those other issues to be addressed. Some of those issues include some newer mood disturbances, like Anissa was referring to. So whereas early on in Parkinson's, depression and anxiety can occur, and in fact, these can occur even before the diagnosis as almost a prodrome. Over time, with mid and later stage Parkinson's, sometimes mood disturbances become more complex. And sometimes people can develop behavioral changes that are rather unusual and sometimes not recognized for what they are. Some of them can be impulsive behaviors where people, particularly who are taking dopamine agonist medications like Mirapex, Pramipexole, Ropinirole, Requip, Nupro patch, Rotigotine patch, apomorphine, those kinds of medications sometimes can make people with Parkinson's more likely to have impulse control disorders, meaning that they excessively do things behaviorally that they weren't doing previously, such as excessive spending of money, rash decision-making, gambling, shopping excessively, buying multiples of things that they don't need, hypersexuality, preoccupations with pornography. As odd as these things sound, they can happen, thankfully, not the majority, but nonetheless, if they happen, we want to catch those things because we then adjust medications and often can make them go away and manage them. And so as uncomfortable as some of those topics might be to discuss, they're critical, because the last thing we want is for these things to get worse or spiral out of control. So I think that impulse control behaviors are something to be on the lookout for. And sometimes people develop behaviors that are repetitive, like punding behaviors. And that is a repetitive, purposeless movement where somebody insists on maybe taking their junk drawer, emptying it out, and kind of rifling through it with the intent of organizing it, but not really ever doing it. These kinds of behaviors can kind of sneak into mid and later stage Parkinson's that are sometimes a real source of frustration for care partners and are often unrecognized and can absolutely be part of Parkinson's. I think also occasionally in mid stage, definitely more in later stage, people with PD can develop visual perception changes. I'm not talking about blurry or double vision necessarily. What I'm talking about is illusions. Sometimes seeing something that is there and mistaking it for something else, such as a bedpost in the bedroom might be perceived as a tree, something that has no business being in there. So it's something that is there, but mistaking it as something else, that's an illusion. Sometimes it goes a step further and becomes a visual hallucination. And again, some medications are more likely to exacerbate that than others. Those dopamine agonists I mentioned are more likely to rev up hallucinations in someone with PD. And by visual hallucinations, I mean seeing something that just plain is not there. And these are often people, insects, animals, outside or in the home. And usually they're not bothersome. If they happen, the patient or the person with PD recognizes them and early on has insight and says, oh, that's a hallucination, but over time, sometimes people lose that insight because they seem so real, just as real as anyone else would seem. Usually there's no auditory component to these hallucinations and you can't converse with them. So sometimes people are able to tell their hallucinations because they talk to them and they don't talk back or they make no sound. But what becomes a problem is that in more advanced stages, if hallucinations are present, people often lose insight and think that they're real. Again, they're not often bothersome or scary, but they can pose problems, safety risks, and people might be trying to interact with them or not going into a room because someone else they think is in there, that sort of thing. So illusions that can then evolve into hallucinations are something else to sometimes be on the lookout for in mid-stage Parkinson's, definitely in later stages, that becomes a higher risk.
We had a question in regards to depth perception and later Parkinson's, noticing apparent inability to come close enough to an object to be able to pick it up and then leaning in causes a fall.
Yeah, that is a common problem. And I wish we had good solutions for that. So what we see is that sometimes people go to put something down on the counter and miss it because they have a hard time with depth perception, or more significant, try to sit in a chair and really aren't good at assessing where they are in relationship to the chair and fall. And so the best thing we have for that is to really work with an occupational and a physical therapist to work on hacks and strategies on how to better get into the chair or to touch certain things first, and to have sort of a stepwise plan on how to deal with that. I know that's not a perfect process, but it's the best we have. We don't have medications that help that. It's also worth considering whether or not a neuro-ophthalmology assessment makes sense. Sometimes people have a different process going on in the back of their brain that can coincide with Parkinson's or other conditions that makes it so that they really have a hard time seeing with their brain. You know how, obviously our eyes are seeing, but our brain is also seeing. And neuro-ophthalmologists or some certain ophthalmologists are able to distinguish what really is going on there. So if there is a question, that's another consideration to get a better understanding on that. But usually it's the rehab therapists that play the biggest role in coming up with strategies to help with safety when there are issues with depth perception, and also thinking about avoiding stairs or having grab bars nearby and everything possible to make things as safe as possible.
All right, and that makes me want to ask a question that came in earlier, but before I do, because it talks about other team members that they should be engaging. Someone wanted to know if you could talk a little bit about the delusions, because the delusional aspects of things can be very challenging for care partners. And is that something that you might see in the later stages?
Yeah, this is an excellent question. And delusions often go along with hallucinations. And what are delusions? Delusions are fixed false beliefs. So paranoia is a form of a delusion. A common delusion, if it happens in Parkinson's, believe it or not, is one of infidelity, where the person with Parkinson's assumes that their spouse is cheating on them or having a tryst or an affair. And it's the strangest thing. That is a common theme. And it's international. It's not just in the US. In people living with Parkinson's, if a delusion happens, that's a common one. Other delusions or fixed false beliefs can include fear of people taking advantage or stealing from you, or a fear of contamination. Some people fear that their medications are being messed with or their food is being contaminated purposefully. Delusions are extremely difficult to handle, particularly for the family. I can speak from personal experience in my own family on this one. It's hard because your temptation as a family member is to want to redirect them and say, hey, that's not true. Here's proof at why that's not true. And if the delusion is fixed enough, no matter how much proof you try to show someone that their delusion is not real, it's not going to work if it's a really set, fixed delusion. And so the way we often suggest is to redirect gently and say, you know what, I actually have another idea, or do your best to redirect away from that topic. Sometimes that's just not possible. Absolutely, this has to be brought up to the medical team, because sometimes adjustments in medications can help the delusion, meaning sometimes lessening the dose of the Parkinson's medication, oftentimes eliminating the dopamine agonist, if that's part of the regimen, those medicines I mentioned before. Sometimes lessening the dose or making them more frequent, smaller but more frequent doses. There are a variety of things that can be tried from a medication standpoint to help delusions. And sometimes addition of medication, an antipsychotic medication. There are only 3 antipsychotic medications that are safe in Parkinson's disease. The newest one is Nuplazid, pimavanserin, that focuses just on the brain chemical serotonin. And then there are 2 older ones that focus on dopamine, but are still safe in Parkinson's, quetiapine or Seroquel, and clozapine or Clozaril. Clozapine's been around a long time and is pretty effective, but it requires frequent blood draws to check white blood cell counts. So people don't reach for it first because of the annoying need to get frequent blood draws, but it can be quite effective for psychosis, meaning delusions and or hallucinations, but very, very difficult, and something that can also creep in and not be immediately recognized. If you have a suspicion for a delusion, it's worth bringing it up to your provider and using the patient portal. I think somebody put in the chat, use of patient portal. That is a great way to communicate if you have that sort of relationship with your spouse, to be able to share the patient portal and communicate with your medical team.
So I have 2 questions, and I know we're getting close to the end, but there's 2 that I want to address. And one was related to a team. So a message had come in, you know, their specialist hasn't really engaged other specialty team members. And you mentioned, you know, the neuro-ophthalmologist. Can you just quickly maybe touch on some of the other players on the team that might be engaged, especially at the mid and the later stages?
Sure. It's a tricky thing because on the one hand, you don't want to spend your whole life going to medical appointments and seeing a bunch of specialists. But on the other hand, you want to make sure that all of the aspects of your well-being that Parkinson's impacts are being addressed. And not everything can be well addressed by a neurologist as much as we try. So for example, people with urinary symptoms that become really problematic, frequency, urgency, incontinence, that often needs to be handled by a urologist, a specialist in bladder function and dysfunction. We try as primary care or neurologists to treat those things, and sometimes we're successful, but if we're not, urologist has to be involved. Sometimes a sleep specialist is another important member of the team, not to meet with frequently, but perhaps to have a one-time consult and maybe a sleep study to see how sleep is going and how best we can optimize good sleep, because that is so impacted by Parkinson's in so many ways. Having a check-in with a sleep specialist is another good idea. A dermatologist checking in once a year at least is a good idea, because there is a higher likelihood of developing melanoma which is serious skin cancer when people have Parkinson's disease. So making sure that people check in with a dermatologist for a skin check once a year is also highly recommended. So this isn't frequent necessarily unless they find something. It's meant to be just a check-in. Having all of your rehab specialists, physical, occupational, speech therapy, checking in with them as often as you can to work on strategies for getting off the couch, getting out of a car, in and out of a car, stretching, mobility, all of those things. That's definitely part of the team at any stage. A GI doctor or a gastroenterologist is sometimes helpful if people have really severe constipation. Constipation is prevalent in Parkinson's, usually even before the PD is diagnosed. So that's always going to be part of the picture because the gut moves slower. Sometimes we can handle it in neurology or primary care, but other times we need to bring in a GI doctor to make sure we're not missing something or make sure there's not some anatomical change in the colon, for example. So having a GI doctor can be a useful adjunct too. Knowing your pharmacist makes a lot of sense because of the variety of medications that are provided and the potential for interactions. Making sure all of your care providers are communicating. That is easier said than done too. But I'll tell you, the good news is that these electronic medical record systems that we all have are doing a much better job at talking to each other so that I can access information from outside of my healthcare system about a specific patient if I want to, or if I need to. And it's easier than it used to be. So communication between these providers, particularly if they're not at the same healthcare system, is critical. I think that's a good smattering of other types of providers that make sense to have kind of as your team, and always to ask your main neurology provider, hey, you think it would make sense to have X, Y, or Z other specialists, to kind of work as a team together? Because, I don't know where this is going, and maybe my GI tract or my constipation is going to be a bigger issue in the future. And I just want to be prepared and proactive, not reactive.
Thank you. I know we're getting so close. We're getting such great questions. So I know there was one, couple of people are like ditto. I want to know what sort of things, what the end stage or, of Parkinson's might look like. And I know it could be a little bit different, but can you, yeah, that's a big question for a short period of time, but Are there some key things that care partners should be looking for? And I'm going to tack on this last person's question is, are there also what you might call a PD event that might temporarily or episodically exacerbate symptoms that could potentially not be end stage, but resolved?
These are some great questions. Gosh, time flies.
I
yes.
know. We're just scratching the surface.
I know, I could talk for a few more hours. But yes, there are some PD specific events that can happen. So as you start to learn, as PD progresses and gets to more middle and advanced stages, there's less of a buffer, which means that if somebody develops an infection, even a straightforward infection, it impacts them more than it once did. Even a bladder infection, you can have no symptoms of urinary trouble and have hallucinations or confusion or fatigue or just be out of sorts as a result of having a basic UTI, urinary tract infection, on top of the Parkinson's. So it's as if people have less reserve to be able to withstand other medical events. And those are kind of Parkinson's events. When people have advanced Parkinson's disease, sometimes they experience really bad days. I mean, there are good and bad days throughout the course of PD, but bad days where they just can't get out of bed when they otherwise can. Or days where they are just completely not wanting to interact. There are days when people, particularly if somebody has advanced Parkinson's and dementia, where they are asleep and really aren't easily aroused. And sometimes these people are taken to the ER, the emergency room, and there's a workup done, nothing's found, and we're left with, well, that was like a Parkinson's type event where somebody with Parkinson's advanced and dementia just was kind of unresponsive for no other reason. So that can happen in advanced stages. I'd tell you some guideposts on things that we look for in advanced stages of Parkinson's to herald that time is shorter would be some obvious things, but things worth mentioning. Ongoing weight loss. Now, people lose weight in Parkinson's a lot of times, except when they get DBS, sometimes people gain. But in general, people tend to become skinnier during the course of the PD. But if they're really getting skinny to the point of being malnourished, where there's a concavity here and you can just see wasting away of somebody losing a lot of weight. That's clearly end stage for the most part, unless there's another medical issue happening. People that are just falling more or having repeated infections or in and out of the emergency room, spending a lot more time in bed, and having trouble swallowing or choking. These are potential symptoms in later stage or really advanced Parkinson's. It's not a given, and that goes back to my earlier point that Parkinson's is so variable. It's not a given that everyone's going to end up in that state. But these are some of the red flags for end stage or really advanced Parkinson's. People being really frail and at risk for a catastrophic fall, God forbid a fall where they fracture something or have an internal bleed, or at risk for an aspiration event where even saliva, not just food or liquids, end up in the wrong pipe into the lungs, starting, a pneumonia. And if they're otherwise frail, it's really hard to overcome that. So those are some of the more frightening features that can potentially occur in advanced Parkinson's disease.
And is there like an average timeline of how long this stage lasts?
No, I'm being honest. I wish I could give you a frank number. It really, ideally at this point, you've had a longer relationship with your care team and they're able to kind of gauge the slope of change that you've been experiencing, that your loved ones have been experiencing, and they can make predictions based on having multiple visits with you over time and seeing things. Sometimes people buoy up if they get more advanced care or more frequent around the clock care. Sometimes people buoy up for other reasons or another medical problem is well addressed. So it's really hard to say that there's a time frame. I wish I could be more specific, but I just don't want to mislead anybody. I hate to end on that note.
Yeah, well, and I know we're over, and I will ask this last thing, so I know people are starting to pop off, but people have heard that you don't die from Parkinson's, you die with Parkinson's. And I know that's a hard one, but that is something a lot of people want to know. So, a lot of people, when they get diagnosed, are around 60, not all, but around 60, and they live with it for many, many years. So is it true that it could, or is it that they're aging and there's other medical conditions that are a part of that?
People can die from Parkinson's. Not everybody will, but people can die from Parkinson's. And people over 65, the CDC ranks Parkinson's, it varies each year, as the 13th or 15th leading cause of death. I think years ago, not that long ago, as neurologists, we used to actually look forward to saying, you're not going to die from Parkinson's. You better find something else. It's not going to be Parkinson's. And that made us feel better, but it wasn't completely true. And we didn't mean to be deceptive. That was our belief. But over time, we've come to realize that if someone lives long enough with Parkinson's to reach a very advanced stage that puts them at risk, particularly for a bad fall, aspiration, or other complications, they can die from Parkinson's. So it is possible. And I think this always warrants a conversation with your physician. If that's something you want to know, say, how likely is it that I will die from this? And your clinician should be able to be honest with you if you want that information, to say, well, given that you're at this age and this stage and you have all these other things going on, I think it's less likely or it's more likely. So it depends. But again, we definitely don't want to mislead people into thinking you don't die from Parkinson's, because it is possible. It is.
Well, thank you for that honest answer, because I know it comes up a lot and it weighs on people. And I know that we've kept you over, and everyone that stayed on. So I want to thank you so much for that. As someone said, I think that we could have a part 2 and continue this conversation, because we've only scratched the surface. I will tell you that if you didn't grab it, the links that Calissa dropped in, the roadmap to care and the planning for the future, that document does break down each stage, the early, mid, and late stages. What are the symptoms you might see? What are the treatment approaches the doctors might be addressing? What are things as a care partner you should or could be doing at this, or consider doing at each of those stages? It doesn't answer every question. Obviously, it's not going to answer specifics, but it's more, like I said, a roadmap to kind of help you in your planning. And then the planning for future is sort of a supplement, because as some of these things that Dr. Vaughn has talked about is, you know, getting some of these advanced directives figured out, thinking about having your home evaluated if you want to age in place, talking with the financial planner if you want to look at what your resources are financially to bring in assistance in the home or pay for assisted living, those kind of things. You don't want to wait till the last minute to try to figure that out, because then it gets a lot harder. So we encourage you to kind of look through those, and it's a starting point. And then I will let you know, because it also goes to some of the questions that someone had was, you know, who should be on the team and how do we communicate with the physicians? So our next program in the series is October 28th. We're going to be talking about empowering communication, you know, the importance of talking to your team, who should be on your team, and how to navigate that if you don't go to a center that has all the team members available to you. And we're going to be talking about how to understand that Dr. Vaughn was starting to talk about, not just motor symptoms, but what is the non-motor things that you need to be looking for and understanding so you can communicate that. So that's coming up on October 28th. Dr. Vaughn, I can't even thank you enough for this, because you honestly, the way you have been able to explain all of these things, especially what the neuropalliative approach is so important. I thank you for that compassion. I know I'll talk offline with her about maybe having a part 2 of this. I'm not going to put her on the spot now, but it really is something that we could delve into deeper. And I think that it's a conversation that needs to continue, because there's just so many questions that are just not addressed regularly. So thank you so much for.
My pleasure. Thanks for inviting me. I really look forward to speaking with patients and families about Parkinson's. And I just want to remind everybody that honestly, that at the end of the day, our goal as a medical team, your neurology team, whoever's involved in your care, is to help people live as well and as long as possible with PD. And it is possible to live well. We've just got to come at it from multiple directions, because it has such an impact in so many ways. And so hopefully this is meant to help empower families know what questions to ask, or be inspired to ask other questions, and to really partner with your care team as much as possible.
Thank you. And thanks to Karen, who made this possible, who did this survey. They gave us this data that lets us know, you know, your experience. It's another way that you are telling us what your needs are. So thanks so much for that. So in PMD Alliance style, for those of you who already have your video on, and those you don't, let's prepare to just thank Dr. Vaughn with our wave of gratitude. So across the miles, across the US and maybe beyond, we thank you for your time and such an amazing conversation today. Thank you, everybody.